Good morning, everyone. My name is Addie Dotson. I'm one of the chief residents here. We will go ahead and get started. As a reminder, the CME code I put in the moderator section of the people tuning in to RGR. Today is 130416. And I will go ahead and introduce Dr. Shaw before he starts to share his screen. Dr. Shaw is the chief of the Division of Pediatric Nephrology at the University of Louisville School of Medicine, and he serves as the director of both the ACMGE Pediatric Renal Transplant Program and the Pediatric Hypertension Program. He is the co-director of the Norton Children's Tuberous Sclerosis Clinic. He earned his Bachelor of Medicine and Bachelor of Surgery in 2005 from N.P. Shaw Government Medical College. He finished his coursework at the University of North Texas Health Science Center in the Master of Public Health program before completing his residency in 2010 at the Columbia University Irving Medical Center, Harlem Hospital Center. He then went to UPMC Children's Hospital, Pittsburgh for fellowship in pediatric nephrology. He's also been recognized for his work as an educator and physician. In 2016, Consumers Research Council of America selected Dr. Shaw as one of America's top pediatricians, and 3 years later, in 2019, U of L's Department of Pediatrics named Dr. Shaw its Outstanding Clinical Professor of the Year. I know that all the residents truly love all of his discussions on nephrology, and we hope that this is an excellent grand rounds about chronic kidney disease and renal transplantation. Again, the CME code is 130416, and I'll be monitoring the chat to let Dr. Shaw know if there's any questions during his presentations. Dr. Shaw, please take it away when you're ready.
Thank you so much for the introduction. Thank you for this opportunity. Can you see my slides?
Yes, we can, Dr. Shaw.
Thank you. Thank you for this opportunity, and I'm going to mainly focus on pediatric chronic kidney diseases in this lecture in the interest of the audience, but I will touch base briefly about renal transplant trends here at Norton Children's. So my content specifications mainly, I want to talk about what is CKD and identifying the stages of pediatric CKD, understanding the major etiologies of CKD and ESRD in children, and evaluating major factors that can affect the progression of CKD, as well as understand the complications. And then we'll touch base a little bit about the trends of transplant trends here at Norton Children's. So what is glomerular filtration rate? And that's a question that residents ask, and medical students ask, and it's easy to, like, we generally understand is how much the glomeruli are filtering. But it's important to understand the GFR in the context of heart and kidneys. And so we know that cardiac output is like normal cardiac output is standardized based on body surface area being 1.73 meters square. So cardiac output is like 5 liters per minute. And kidneys are one of the most vascular organs in the body. And so kidneys receive 20% of cardiac output. So that 20% of 5 liters goes to the kidneys. So if you actually calculate the renal blood flow, it comes out to be 0.2 times the 5 liters per minute, which is approximately around 1 liter per minute for the renal blood flow. And that's why we see with cardiac diseases, acute kidney injury, and even chronic kidney diseases are very common. But just let us understand that the red blood cells here, they do not get filtered. So actually what we are looking is the renal plasma flow. And if you want to convert renal blood flow to renal plasma flow, what you do is you multiply the renal blood flow, that is 1 liter per minute, and multiply in 1 minus hematocrit. So let's assume that the normal hematocrit is 40% or 0.4, then 1 minus 0.4 will be 0.6. So renal plasma flow, it comes out to be around 600 mLs per minute. And so that's the one which gets filtered. So we want to look at the renal plasma flow as an index for the glomerular filtration rate, because the red blood cells do not get filtered. And then from renal plasma flow, if you have a good good filtration fraction, which is around 20%, you have 20% is generally a good filtration fraction in the glomeruli. So you multiply the 600 mLs per minute by 20%, that's 0.2, which comes out to be 120 mLs per minute. And so this is important to understand in context with the cardiac output, and cardiac output plays such an important role in glomerular filtration rate. And so normal GFR is around 100 to 125, but just pay attention to the units are ml per minute per 1.73 meters square. And GFR is standardized to the body surface area of 1.73 meters square. So let's understand that in context too. Coming to the next slide, renal blood flow is also dependent on the age, because in utero, renal blood flow is only 3% of the cardiac output. But as the child, and that is because of high resistance in the placental circulation, and it slowly improves to around 10% at 2 weeks of age, and then 15% at 8 weeks of age. So that is, and then by 1 year of age, it reaches the adult values of cardiac output, percentage of percentage of cardiac output going to the kidneys, which is 20%. So when we are talking about this, there is a period called honeymoon phase where there is an increase in renal blood flow after the child is born, and that is between 1 to 8 weeks. And what happens there is sometimes we see that some of the children who are born with like chronic kidney diseases or have high creatinine at birth, you may notice if you're in the ICU that after 1 or 2 weeks, their creatinine may start to improve slowly if they have kidneys and some viable kidney tissue, and that is because of the improvement in the renal blood flow during that time period. And also we want to think of cardiac diseases, or maybe as a prematurity, because prematurity can be important factor. ICU admissions, when the renal blood flow is compromised, in those patients, the GFR can go down, and AKI can get converted to CKDs or chronic kidney diseases. When we are talking about GFR by age, let's understand that the preterm or premature baby, and again, this can be because of the poor renal blood flow in the babies, but also like in premature babies, the nephrogenesis is not completed until 34 weeks of gestational age. So you will see that if a child is born which is premature less than 34 weeks, then the GFR is only 10 to 15 mLs per minute. A term child, term to 3 days, the GFR is 15 to 20. And as the renal blood flow improves, you start seeing improvement in the GFR. So at 2 weeks and 8 weeks, you are seeing improvement in the GFR. So you are seeing 35 to 45 to 75 to 80. And at 1 year of age, you will reach around 90 to 100. Normal adult GFR is 100 to 125, as I discussed earlier. But that's why we want to understand that if a child is premature, then they are at high risk of CKDs too. Another determinant apart from renal blood flow for the GFR is filtration fraction, and it's important to understand filtration fraction in context with the glomeruli, because the blood that flows in this glomerular capillaries, these are the afferent and the efferent arterioles, and as the blood flows to the glomerular capillaries, it exerts an hydrostatic pressure, and that's an absolute important factor that helps with the filtration fraction. Also, you need to understand that there are capsular hydrostatic pressures which work in the opposite direction. So if there is more fluids in the capsule, then there is a tubuloglomerular feedback that we sometimes see, and that can decrease the glomerular filtration rate, and we see that sometimes with obstructive kidney diseases. And so that's also needs to be kept in context. And another factor, which is the osmotic pressure in the blood itself. So as you know, if there is more protein, more osmotic pressure, that will not allow the filtration to happen as well. So those act in the opposite direction. The glomerular blood hydrostatic pressure acts in the direction of promoting filtration. So when you are looking at the net filtration pressure, it's the hydrostatic pressure in the glomerular capillaries, and you then subtract the osmotic pressure inside the blood as well as subtract the hydrostatic pressure in the capsule. And that's roughly around 10. I mean, it's just a typical range. I mean, it can vary depending on conditions, but that amount of filtration pressure will exert a filtration fraction of 20%. As I'm talking about, as I'm talking about, filtration fraction is important because if you have a glomerular diseases or cystic diseases or congenital obstructive kidney diseases, even in post-AKI states, this filtration fractions and pressures can get compromised, and that can lead to that can be important factors for chronic kidney diseases.
Dr. Shaw, there's a question in the chat from Dr. Schickler. Is the
Yes.
lower concentrating ability in the first few days of life based on the renal blood flow you describe?
So the lower concentrating ability is mainly related to the immaturity in the tubules, and the concentrating ability of the kidneys is more so in children who are born with renal dysplasia or hypodysplasia. And I'll touch base that in my next slides as we go further. But that's more the decrease in urine concentrating ability, if I'm understanding it correct, maybe is related to the tubular immaturity. I will touch base that further in my next slides. Also, we need to look at other determinants, the number of glomeruli, because in conditions, let's say you have a kidney disease and, for example, there is renal hypodysplasia or even cystic kidney diseases, or sometimes you hear of conditions like reflux, nephropathy, renal scarring. In those conditions, the glomerular mass or the number of glomeruli are affected, and in those conditions, you can have chronic kidney diseases because each glomeruli contributes to the GFR. So that's why it depends on the number of filtering glomeruli. So those conditions can get you can see those conditions kidney diseases, chronic kidney diseases. So having understood the main determinants being renal blood flow or filtration fraction or number of glomeruli, I'm going to talk about just the chronic kidney disease. How in chronic kidney disease we'll try to first talk about how do we measure GFR, and then we'll try to define chronic kidney disease based on how we measure the GFR. So typically in pediatric patients, GFR is measured using the revised Squartz formula, which is 0.413 times the height in centimeters divided by serum creatinine. So that's that value gives the GFR value standardized, and that's been used mostly by residents, by us many times when you have the creatinine values, and that's the current standard that we use. But more recently, KDIGO, or the kidney disease of the National Kidney Foundation, are recommending using cystatin C and creatinine together to measure the GFR, and there are calculators. One of the calculator I have attached is from the National Kidney Foundation, and when you have cystatin C and creatinine together, then that will lead to more accurate estimation of GFR. Now let us understand that cystatin C is a protein that is present inside the cells, and unlike creatinine, it's not secreted by the tubules. So you can have a better estimation of GFR. It's not, and I'll talk about the advantages of that in the slide. But when we are talking about creatinine has advantages. I mean, creatinine is widely available, it's inexpensive, but creatinine can get affected by hydration status. You have somebody who is very muscular, it depends on the muscle mass too. It gets affected by age because you have babies, children whose normal creatinine may be 0.4, 0.5. Somebody who's adolescent maybe have a normal creatinine of 0.8, 0.9, and so it gets affected by age and protein intake as well. And it can lead to overestimation of GFR because 10% of creatinine, 10% is secreted from the tubules, so you end up overestimating the GFR many times with creatinine. On the other hand, if you do cystatin C is rarely affected by the hydration status. It's not rarely affected by the muscle mass or medications. Now, there are some medications like Bactrim, which can increase the creatinine levels, but cystatin C, you don't see that kind of effect. Also, it does not alter with age in children who are more than 1 year of age. So let's say we have a child who is 3 years or 4 years or 5 years, and you compare that with somebody who's adolescent, the cystatin C levels being high would give you an idea. It will be one number like 3 or 3.5. That would probably indicate a CKD stage 4 or 5. And so that does not change like creatinine after 1 year of age, but it does take time to get the results. It takes a couple of days here to get the results. Creatinine is fast, but cystatin C it is expensive. Sometimes if you are having hyperthyroidism or receiving steroids, then their levels can be high. So that needs to be taken into context when you are measuring cystatin C. But the current recommendation is use the combination of cystatin C and creatinine to measure the GFR. It works better to measure to classify the stages of CKD, and we use both of them in our clinics. So this was a study. This was a meta-analysis that showed. This was a meta-analysis done, which came out from the NEJM, and it showed that there were 3 things that were tested using this meta-analysis: death from any cause, death from cardiovascular disease, and progression to ESRD. And these are forest plots. And what it says is that when you are using a meta-analysis, when you use cystatin C as the marker of GFR compared to creatinine, it strengthened the association. So you can see that in these lines, all these associations of GFR and death from any cause was more strengthened when they used cystatin C in place of creatinine. Similarly, the death from cardiovascular cause and GFR was strengthened. The association was strengthened when they used cystatin C compared to creatinine. And same, there were some more with progression to ESRD. So that's why some studies are saying that cystatin C based GFR is a better predictor to establish the association of GFR with all-cause mortality and death from cardiovascular diseases. So now, having understood what is GFR, how do we measure GFR, let's define CKD. And it's a very simple definition. There is not too much into it, but we need one out of two of the below criteria. The first criteria is if the GFR is less than 90 mLs per minute per 1.73 meters square for more than 3 months. So if you have somebody's GFR who is less than 90 for more than 3 months, you can include them as CKD. But some children can have even a normal GFR, like more than 90, but that if they have other things like structural renal damage, like if you have a renal ultrasound with cyst in the kidneys, or sometimes some hypodysplasia, in those conditions, you can still call them as CKD. If you have glomerular tubular disorders, like somebody who has proteinuria for more than 3 months, can still be called as CKD. So the CKD definition is wow. I mean, it's big. So a lot of children who even have who can have normal GFR but can have like abnormal renal ultrasound or congenital kidney diseases can qualify for the diagnosis of CKD. So that's a very simple definition of CKD. Having said that, I'm going to talk about the CKD stages. So, so there are 5 stages of CKD. You have stage 1, which is a GFR more than 90. But as I said, you can have abnormal renal ultrasound or persistent hematuria, proteinuria. That can be stage 1. You know, you have a normal GFR, but if there is abnormal ultrasound, then that can be stage 1. Stage 2 is 60 to 90. Stage 3, again, is 30 to 60, but it's divided into 3A and 3B now, which is 45 to 59 for 3A, and 3B is 30 to 44. And those are mainly for like when you're billing those CKDs, you will need those classifications too. Stage 4 is 15 to 30. And stage 5 is less than 15. And when a child is on dialysis, that is stage 5D. That's when they are on dialysis. That will be they are called 5D. What is end-stage kidney disease? It's mainly if a child who has stage 5 CKD and then the child requires dialysis. At any point they require renal replacement therapy, then the patient will be diagnosed having end-stage disease, as having end-stage kidney disease. So you can have a child with stage 5 CKD and they are not on dialysis. You do not need to call them end-stage kidney disease if they are not on dialysis. But the moment you start them on dialysis, you have to declare them end-stage kidney disease, and that's how that's the definition of end-stage kidney disease is established. So let's understand the main causes of CKD in children. Again, when we are talking about the causes, the main causes are the congenital abnormalities of kidneys and urinary tract. They are by far the most common cause of chronic kidney disease in children, and those are congenital anomalies. It's labeled by this nomenclature as K-cut. Then you have glomerular diseases like steroid-resistant nephrotic syndrome or FSGS, which are around 20%, and other causes like HUS or post-AKI. There is a genetic condition called cystinosis, which we have a couple of patients of too, and transplants too. So it's a rare condition, lysosomal storage disorder. So some of those rare conditions can also cause CKD down the line. So those are the main causes. When we are talking about K-cut or congenital anomalies of kidneys and urinary tract, there are three common causes of it. They are obstructive uropathies, like posterior urethral valves that we see in boys who are born in the with valves, and then reflux nephropathy. It's again a very common condition causing CKD. Child who has a history of recurrent urinary tract infections, or child who are born with structural renal diseases like hypodysplasia. A lot of them have genetic components to it, and I'll come back to my next slide about how genetic studies have changed the diagnosis of this condition. So those are the main causes when we are talking about CKD. But the big thing is that there are two groups. The one group is K-cut, and the other group is glomerular diseases. And we'll try to talk down the line about these two groups and how they lead to progression of CKD in these two groups. And when we are talking about ESRD, now we are not now talking about ESRD, not CKD, but when we are talking about ESRD causes, you can see that the K-cut and the glomerular diseases are almost equal. So the point being that the glomerular diseases progress faster to ESRD than the K-cuts. So that's why we see a lot of glomerular diseases as a cause of ESRD. And there are other causes too, like nephritis or hereditary conditions, but there is equal distribution among the glomerular diseases and K-cut when we are talking about as them is having an etiology of ESRD. And I'm going to talk about evaluation of CKD. Mainly when we are trying to look at the evaluation, we talk about history, symptoms, physical exam, and lab investigations, imaging studies. We'll talk about identifying factors that affect the progression of CKD and how do we monitor and treat complications of CKD. One of the most important things when you are taking a history of a child with CKD is to look at the prenatal ultrasounds, because prenatal ultrasounds can give you a clue to diagnosis. Sometimes some child in the prenatal ultrasound, babies have cysts in the kidneys, or they have poor growing kidneys. Sometimes they have absence of kidneys, what we call as agenesis. They have hydronephrosis. Posterior urethral valves is an important condition that can be missed if you do not do an renal ultrasound. So if you do, this is a prenatal ultrasound of a child who has posterior urethral valves, and you can see that there is something called a keyhole sign that they look at, and there is a the posterior urethral valves would be presenting there is bladder distension, hydronephrosis, bilateral hydronephrosis. So those kind of things you would be looking for on the prenatal ultrasound. And there is a dilatation. Here you can see there is a dilatation of the posterior urethra on the prenatal ultrasound in a child who has posterior urethral valves. Also, you want to look at the amniotic fluid volume, because many kidney diseases like posterior urethral valves or renal agenesis can have low amniotic fluid volume, or called oligohydramnios, and that can lead to Potter's sequence. What is Potter's sequence? Potter's sequence is a condition when you have oligohydramnios, which causes fetal compression, and that is because of the decrease in the fetal urine excretion. And because of this compression, because of the fetal compression, they have peculiar faces, like they have low set ears, they can sometimes have beaked nose, they have prominent epicanthic folds. They sometimes can have very severe lung disease, because amniotic fluid is required for maturation of lungs, and they can have respiratory failure, they have lower limb deformities, and examining for the lower limb deformities, even hip dislocation, a congenital hip dislocation, sometimes if there is a positive family history of kidney diseases, should warrant an evaluation for kidney problems in the babies. So look for those things as well. Sometimes polyhydramnios can be seen in some other kidney diseases if there is a renal tubular diseases where you're not like they have congenital renal tubular diseases, or renal dysplasia where there is decrease in urine concentrating ability, congenital nephrotic syndromes. You can see polyhydramnios too. When you're talking about birth history, prematurity or neonatal asphyxia, Apgar scores again are important. 1 and 5 minute Apgar score. Sometimes if there is severe prenatal hypoxic ischemic injury to the kidneys, that can lead to acute cortical necrosis, then that can lead to significant chronic kidney diseases down the line, and may require the need for kidney transplantation in the future. So that's an important factor when you're looking at the birth history to look at the Apgars. Single umbilical artery, I often get this question, is whether this warrants an evaluation of kidney diseases. Now, there are 30% of cases of renal hypodysplasia or aplasia which can be associated with single umbilical artery, but I would only recommend an ultrasound if there is a positive family history. So just talk about the family history in those who have single umbilical artery, and talk to see whether there is a congenital kidney diseases in the family. Umbilical vessel catheterization, like if they had required umbilical lines, then that can increase the risk of renal vascular thrombosis. So that's also another important part in the history that you want to talk about. When we are talking about family history, and again, this is so important because nowadays we are doing a lot of genetic studies in children with CKD, and many of the cystic kidney diseases or renal hypodysplasia conditions can be associated with family history. There is a condition called brachioautorenal syndrome. So we look at the ear pits in the family, and it's not always the case that having an ear pits many times does not mean that they have kidney diseases. You want to again look at the family history. So if you have a child who is born with ear pits or they have preauricular pits, then you want to take the family history, see if there is a positive family history, because usually this is an autosomal dominant condition. So you would find a positive family member who has some sort of kidney disease. Sometimes the penetration is variable, but it's important to still get a good family history when you see a child born with preauricular pits. But there is brachioautorenal syndrome, which is from the EYA1 gene mutation, which can be causing renal dysplasia with preauricular pits. Another syndrome which is very common is renal coloboma syndrome, which is caused by PAX2 gene mutation, and you would look for coloboma in the eye. It's in the eyes. So you want to have an ophthalmology evaluation in those patients if there is those mutations. When you're talking about family history, you want to look for conditions like polycystic kidney. So this is an ultrasound of a family member who had polycystic kidney. So you can see this large cyst here. And if there was a cystic kidney disease running in family like polycystic kidneys, then that needs to be looked at the family history. When we are talking about symptoms, chronic kidney disease is a silent disease. It usually does not have symptoms, but there can be some clues that you can get that can point towards the diagnosis of CKD. So I'm talking about most of the congenital anomalies of kidneys and urinary tract. They can present with polyuria and polydipsia, so they have decrease in urine concentrating ability. So, and they also crave salt, they crave pickles, they like sodium, and that can be say, oh, my child craves pickles, they like pickles all the time, and they are like peeing a lot, they are drinking a lot. That can be sometimes an initial clue because some of the structural renal diseases have decrease in urine concentrating ability, and that was to answer this question again with renal hypodysplasia. Sometimes when you want to talk or look about history of recurrent UTIs, because reflux nephropathy, again a very common condition that leads to CKD, and asking a history of UTIs, even sometimes it's not UTIs, like prolonged unexplained fever in the past, that can give you a clue of UTIs. And these UTIs or kidney infections can lead to renal scarring. Sometimes if there is bladder issues or posterior urethral valves, you want to talk about dysfunctional voiding. We have children who have been diagnosed with posterior urethral valves as late as 3, 4, or 5 years of age, and the reason being is sometimes they do not get the ultrasound done in the 3rd trimester, and this posterior urethral valves conditions can be missed, and by the time they are diagnosed, it's probably too late. But this is a condition that can significantly, but if we are treating that condition on time, the prognosis can be vastly different, and so it's important to diagnose this condition on time. Sometimes fatigue and poor academics can give you an idea, but again, this is a very silent disease, so you generally don't have any symptoms. So when you're seeing a child with on physical, I talked about some of the important things you can look, like when a baby is born, like single umbilical artery, or if there is a congenital dislocation of hip. Sometimes look at the blood pressures and short stature. You are seeing a child in the clinic and who is not growing well, who has short stature. So one of the causes of short stature is CKDs. If a child is born having Potter faces, as we discussed, because of oligohydramnios, or they have preauricular pits, then you want to look for CKDs. If there is a palpable bladder or kidney, and don't forget the lower limb deformities, because even with Potter sequence or even with renal osteodystrophy, which I'm going to touch base a little bit later, but that in those conditions there are bone problems and lower limb deformities. So if you see a child with those conditions, then, or a baby born with that presentation, then look for CKD. Look for kidneys. I'm sorry. So this is renal osteodystrophy. This is what happens when the kidneys are not working well. The bone, it leads to metabolic bone diseases because of high parathyroid hormone, and as a result of demineralization of bones. So this is an example of knock knees, that you see a child in the clinic and who has knock knees. So look at the lower limbs, look at the knock. This can sometimes be seen with CKD. Sometimes you can even see bow legs. So those are all presentation of renal rickets. And sometimes you can see this demineralization. So on the radius and ulna, you can see that there is demineralization, and those can give you an idea of renal rickets. And you want to look at those things as well. This is a child who was born with prune belly syndrome. You can see that there is abnormal abdominal musculature. They have undescended testicles. They have dysmorphic urinary tracts, like they can have vesico-urethral reflux. But we see sometimes neonates who are born with prune belly syndrome having chronic kidney diseases, and sometimes even requiring kidney transplants down the line. But this is a condition that you can see when you're working in neonatal wards and ICUs. And having said that, I want to talk about how we are looking at the genetic studies which are very important when we are talking about CKDs, because our clinic has recently partnered with this company called Natera or Renasite. And the advantage of this this facility is that most of the the insurance covers, because the huge issue when we are sending genetic studies is the insurance and the money and the cost. But with this, the Medicaid mostly covers this. The out-of-pocket maximum cost is $150 that I have seen with the children who have ordered this study, and they screen for 385 genes which are associated with kidney diseases, and I'm talking about the mutations like PAX2 or EYA1. And so that's an advantage, and the turnaround time is around 2 weeks. So I think we have really liked this, and our patients have liked this because of the cost involved, and that's a huge factor when we are sending genetic studies, because sometimes we cannot send genetic studies because of the cost. And so that's something that has changed. But this is a deep sequencing, whole exome sequencing of 385 genes. And we did diagnose recent positive cystic kidney CKD detections. Like we had like 4 children with HNF1B mutation recently, and this is just within the last 6 months since we partnered. We had 3 children detected with PAX2 mutation, 1 child detected with EYA1 mutation. And that's important because sometimes family history, the penetrance is variable. But doing that, if there is an HNF1B, then it's associated with diabetes too. So it's called maturity onset diabetes of young infants. So I can refer those child to the endocrine and look for screen for diabetes on an yearly basis because they are at risk of developing diabetes. So some of these kidney diseases or cystic kidney diseases can be associated with other systemic diseases, and that's why ordering this genetic study early is important. We also are talking about genetic nephrotic syndromes, and when we are talking about genetic nephrotic syndromes, genetic studies are very important when we are talking particularly the steroid-resistant nephrotic syndromes. So these are the layers of the glomerular filtration barrier, and you have the endothelial cells, and then there is the basal lamina, and the outermost layer is the podocytes. And podocytes are the cells that prevent the filtration of proteins. So basically, each of these structures have proteins that play an important role to maintain the integrity of this glomerular filtration barrier. For example, this podocyte, like you look at this podocyte here, and you can see that it is coded by a gene NPHS2, and podocin is a protein inside the podocyte which maintains the structural integrity of the podocyte. So if you have somebody's NPHS2 mutation, they can have congenital nephrotic syndrome. Similarly, the slit diaphragms that connect the podocytes are encoded by a protein called nephrin, and NPHS1 gene mutation can cause congenital nephrotic syndromes and of the Finnish type. So some the neonates or children, babies born with congenital nephrotic syndrome usually have this mutation. There are other mutations in the actin cytoskeleton of the podocytes called ACTN4 or TRPC6. And also in the filtration barrier, there is LAMP2 mutations. So these are some of the mutations that you can see. This is a chart of an electron microscopic slide. So you can see the podocytes, the filtration barrier, and the endothelial cells. And if you do a biopsy, you will see that many times in this nephrotic syndrome, you will see like the podocytes not formed very well, or you won't see like an integrity or so pedicles. Sometimes you can see effacement. So you would see those conditions with genetic nephrotic syndrome as well. So genetic studies are important with nephrotic syndrome. Having said that, I'm going to talk because I won't have last 10 minutes to talk about my transplants. I'm going to talk about some of the investigations that we do with CKD panel, and these are the basic CKD battery that we order in many of these patients. But imaging studies are also helpful, like ultrasound, VCUG on case-by-case basis, and MAC3 scan. Cystatin C is something which we have been ordering in all these children we are seeing in the clinic, because that helps in the better staging of CKD as well as linking them to complications. We check for metabolic bone diseases, so we check the vitamin D and parathyroid hormone. We check the iron studies and CBC for anemia, which is a complication of CKD, and proteinuria, which is a risk factor for progression of CKD. Genetic studies are again important. So let's understand what imaging studies would look like. I mean, you have, and this is a normal kidney, normal kidney that looks like. This is a normal kidney, which is a little bit less. I mean, I would say a little bit less bright than the liver, but it's a normal. You can see some differentiation between cortex and medulla here. When you have an abnormal kidney, it will be more brighter than the liver. So you would see an echogenic kidney, and you would see a loss of corticomedullary differentiation. So you cannot make out what is cortex and what is medulla here. And that's an initial sign and of like any of the chronic kidney diseases. You would see like echogenic kidney with loss of corticomedullary differentiation. Also, when you look at the kidney sizes, you want to look at there is a chart that we follow, And the chart is shows the kidney sizes by age. So somebody who has bilateral renal hypoplasia or lower kidney sizes, that can give a clue to the chronic kidney diseases, and their kidney sizes would be less than 5th percentile for the age. Somebody who has compensatory, who has a single kidney, we want to make sure that that kidney is growing well, and their kidney is growing well, having compensation, having growth above 95th percentile for age. So that's another things where we look at the chart. Also, we look at the ultrasound to look at the cyst distribution. So there is a condition called cystic renal dysplasia, and you can see here that when you have cystic renal dysplasia, you have the cyst, but they are very small. They are confined to the cortex. So you want to look at the ultrasound and look at the cyst distribution. This is a patient who has nephronophthisis, but here the cyst you can see here, those cysts which are they are at the junction of cortex and medulla. So those cysts is not the pattern is different, a little bit different than cystic renal dysplasia with nephronophthisis. So you want to look at the ultrasound and study the cystic distribution. So looking and reviewing the images is very important by yourself. And then if you have ADPKD, you would see like bigger cysts. They are huge cysts, sometimes mostly on the cortex. They are large. They are on the cortex. So you would see such presentation with autosomal dominant polycystic kidney diseases. With autosomal recessive polycystic kidney diseases, you would see smaller cysts, but they are throughout the parenchyma. And that's again a different pattern of cyst distribution that you see on the ultrasound. When you are looking at posterior urethral valves, what you see is bilateral severe hydronephrosis. All this is hydronephrosis here. And the kidneys are like pushed here. So you can see very little kidney tissue, which is pushed outside. So you can hardly see, sometimes there's a loss of cortical tissue. And there is bilateral hydroureter. So these structures are the ureters here on my cursor. And you can see bilateral hydronephrosis and hydroureter. And then you can see distended bladder, and then you can see dilatation of the posterior urethra right here. So that can give you an idea of the presence of posterior urethral valves in this patient. If you are a child or baby born who has a suspicion of posterior urethral valves, you want to do a VCUG. That's a diagnostic study of choice, and you would see that there is a dilatation of posterior urethra here, right here, and it's again a posterior urethral valves are common causes of pediatric CKD. So you want to look at those things as well. VCUG if you are suspecting reflux nephropathy, but just understand that the reflux, as the child gets older, the reflux gets better. So this study is only helpful if the child is very young or small, probably less than 5 years of age, to evaluate for reflux nephropathy. And there are different grades of reflux, grade 1 to grade 5. The higher prevalence of renal scarring happens with grade 4 and 5 reflux. And that's when you can see more renal scarring develop and more risk of kidney infections develop. And those patients many times require surgery to correct the reflux. When we are talking about some of the factors that can affect the progression of CKD, we first need to understand how the GFR changes with age. So as the child gets older, then how the GFR changes. We talked a little bit about that in my earlier slides. I want to talk about how the CKD can affect whether it's a K-cut or a glomerular diseases, which one progresses faster. And we touched base a little bit on the earlier slide. We'll talk about some of the other factors that can affect the progression, like hypertension. We'll talk about proteinuria and some of the other factors. So GFR does change with age, and we talked about that. This is a chart of serum creatinine, and initially when the baby is born, the serum creatinine is high because of maternal circulating creatinine. After that time, that creatinine goes down, and then as the child gets older, after 1 year of age, as the child gets taller, basically, you would see the rise in the creatinine. So usually by the time they are 15 or 16, their creatinine is around 1.9 to 1 roughly in a boy. Depends on the muscle size. You have to look at each patient because every patient creatinine baseline can be different. So you want to look at the muscle mass, whether they are athletes, those kind of things, their protein intake. So I talked about like improvement in the renal blood flow initially, and there is short expected period of renal improvement as the renal blood flow improves. But I want to talk about pubertal years. So you may have a child who with CKD who is doing whose creatinine is 1.5, 2, and you may be thinking that it's not progressing fast enough, but pay particular attention to the pubertal years, because that's when this child can go into ESRD. Because as with the what happens with puberty is that there is steep rise in creatinine, there is steep growth, and sometimes it's hard for the kidneys to handle. And so many times when this patient's present with ESRD during the pubertal years. So look at those things when you are saying have more follow-ups, have more closer follow-ups in CKD children when they reach puberty. Again, glomerular diseases I talked about can progress faster than if proteinuria and inflammation is not controlled. And we want to talk about one of the slides here about how hypertension can play a role in controlling the in determining the progression of CKD. So here this chart compares children with glomerular diseases and which are in the blue part and the blue lines, and the orange lines. So there are blue lines and the orange lines, but there are glomerular diseases, and they're comparing with the renal hypodysplasia or KCUT. So conventional blood pressure control, which was allowing the blood pressure to be at 95th percentile, was compared to the intensified blood pressure control. The blue lines are the conventional blood pressure control, and the orange lines are the intensified blood pressure control. So when you perform intensified blood pressure control or target the blood pressure to at 50th percentile, then there is significant decrease in children who are reaching the primary endpoint in this study. And the primary endpoint in this study was a decline in GFR by 50%. So that's an important thing, is that when you're comparing having strict blood pressure controls can delay the progression of chronic kidney diseases. And the difference is more stark with glomerulopathies compared to the hypodysplasia, because hypodysplasia progress slower than the glomerulopathies. But when you do a stricter blood pressure control, then you would have delayed progression of chronic kidney diseases. Similarly, in this chart, yes.
Sorry about that. There's a question from Dr. Schickler. Is there a difference in CKD rate of progression at puberty in males versus females?
I think the males progress faster because of the growth and the height, and so I've seen more males, but again, there is some studies have shown. I mean, one of the studies has shown equal rates of CKD. So theoretically, I think males do because of the growth, but I think both genders are at risk. One of the other things is to look at the proteinuria, and proteinuria can also cause progression. So here the primary endpoint was decline in GFR by 50% or risk of requiring RRT. So in children who had normal proteinuria, as the years went by, that's a UPC less than 0.2 or urine protein creatinine ratio less than 0.2, a lot of children did not require RRT or renal replacement therapy or did not have a steep decline in GFR. But children who had a very high proteinuria, you can see a lot of children did require RRT down the line. So proteinuria is an important factor that can affect the progression of chronic kidney disease. That's why we use medicines like lisinopril or ACE inhibitors for renal protection. And there are some other factors which can affect the progression of CKD, like hyperlipidemia or vitamin D deficiency. There was a study about allopurinol, whether to use with hyperuricemia, but the study is not very conclusive whether allopurinol actually helps to delay the progression of CKD. But that was a recent NEGM study. And there is no conclusive data on low protein diet to slow the progression of CKD. So I would not recommend this unless there is significant azotemia. because protein is again necessary for the growth. I'm going to, in the interest of time, I'm going to skip a couple of my slides here because I do want to talk about transplantation. But I think one of the things which the residents may find interesting was I want to talk about hyperkalemia management. And that's a question that I get asked many times. So how do we treat hyperkalemia uh, in some of these premature babies? So or in children who have chronic kidney disease. So sometimes Kexilate is used as a management, but it does have gastrointestinal adverse effects with Kexilate. So we many times used decanting of formula with Kexilate. Now that's more safer, and some of the residents may know it, some of them may not. But what actually happens is that you take this Kexilate, and then you pour it in the 24-hour formula, and then you settle that for like 45 minutes to 1 hour, and what you see is a sludge that collects at the bottom, and you discard that sludge and give the supernet into the baby. That's a better way to not have GI side effects, and also try to remove potassium is you can decant the formula using Kexilate to treat hyperkalemia. Also, one other thing which I have found very successful is if you have a child, you can ask, and they like potatoes. They really, I mean, that's high in potassium. But if you pre-soak those root vegetables, including potatoes, for like 1 hour or so, you can effectively lower the potassium content by 50 to 75%. So those are some of the strategies that you can use to help lower the potassium. Okay, I'm going to talk. Having said, I'm going to talk about. Sorry, I'm going to talk about transplantation. So, in our center, we have over 19 transplants done in the last 5 years, and we try to. Some of these causes can include dysplasia or congenital. So those are groups of K-cut with dysplasia or K-cut with obstructive kidney diseases like posterior urethral valves or obstructive uropathies. So those are the. We have children who have glomerular diseases like ANCA vasculitis. We have children we transplanted who has FSGS or congenital nephrotic syndrome, and other causes like cystinosis, post-AKI, Wilms tumor, and chronic kidney diseases. So all of the other causes are there. But those were the 19 kidney transplants that we did in the last 5 years. The age at the time of transplant is varied, but usually they need 10 kilograms. They need to achieve a weight of 10 kilograms before we can transplant a child. And this is the box plot of the age distribution of this 19 children. And you can see here that average age is around 13 years for this child to be transplanted. That's the median age. And the hospital stay, or how many days they need to be in the hospital after the transplant surgery, the median hospital stay duration is around 8 days. So this is a box plot of the hospital duration or hospital number of days in these children. So average median hospital stay is 8 days. Again, we try to focus more on the living donors. Now we have started to do more living donors. So previously, in previous years, we were doing a lot of disease donors. So we are trying to include more living donor kidney transplantations, and that's a good quality metrics for any transplant program. So there were 5 living donors, 14 disease donors. Also, we are trying to do more dialysis preemptive transplants. So you want to transplant a child before they reach dialysis, and those patients have better outcomes. So if you are transplanting a child before they reach dialysis, then they are less exposed to blood products, and there is less risk of rejection down the line as per some of the studies. So we try in the CKD clinics, once the child's GFR is, when they're in stage 3 CKD, we try to look at the blood group, we try to evaluate the potential donors. And when their GFR reaches less than 20 mLs per minute, that's when we start to work up those patients. And usually you do not require dialysis until their GFR is less than 10. So dialysis preemptive kidney transplants, we are trying to do more, and I'm happy to report that we have more dialysis preemptive transplants in the last 5 years than compared to the previous years. The other thing we are talking is we get the scientific registry of transplant, we get the SRTR reports or scientific registry of transplant recipients. That's report we get for our program, which is KYKC. Our pre-transplant mortality rate is not there. I mean, there are some centers like, and the reason why we don't have that is because our wait times are not that high. Somebody who has to be on dialysis for 2, 3, 4 years has an increased risk of mortality. So wait times are important. We do not have that high of a wait time. Again, our 50th percentile, as per this report, our 50th percentile or median time to transplant is 4.1 months. And when you compare it with other regions, even with the current OPO or current OPO program that we are a part of, or current region we are a part of, we are doing significantly better in terms of getting a kidney. So I think we are doing better than Cincinnati too when we are comparing the median time to transplant. So once a child is listed, an average wait time is around 4 months, but it can vary. Some of the children may require higher wait times, but usually we are able to transplant them early after they are listed for deceased donors. This was again, as per the PULSE report, the estimated probability of surviving. This is one of the quality metrics of surviving a kidney transplant. At 1 year, we have 100%. And at 3 years, we are at 90%, but this 3-year data is from 2015 to 2017. This recent data is yet to be updated. We had one patient in 2016 who got a kidney transplant. It was a retransplant, but unfortunately, that allograft did not survive. And as a result, I mean, we took a hit on the 3-year survival rate from that data. But it was a high-risk retransplant with high antibodies in that patient. We try to target now. What is cold ischemia time? Cold ischemia time is when an organ is retrieved from a donor, and from that time to the time it is placed in the recipient. That's the cold ischemia time. Most of the time is in the eyes. We try to target the cold ischemia time less than 11 hours or 660 minutes. And this is the box plot of the cold ischemia time of those 19 patients. And you can see that our average cold ischemia time was around 450 minutes. And so we are staying in the target. When we get an offer, we try to, and I'm going to talk about something new that we started doing called virtual cross match, which has significantly decreased our cold ischemia times. And again, when you have a living versus diseased transplant, when you have a diseased donor kidney transplant, the cold ischemia time is not there because you can get the kidney from the donor. The donor is usually in the next room, and you can get the kidney, and then it's usually like 60 minutes to 75 minutes. So it's not at all there. So that's an advantage of living donor transplant. The cold ischemia time is not that high. So you have less risk of delayed allograft function down the line. But the total ischemia time when we had for a diseased donor transplant is staying at around 450 to 500 minutes. The blood grouping is most important for match. Our HLA matchings have been very poor, but still we have been doing good in the transplant. Median, only 1 out of 6 antigen HLA match we have for this group of patients. So many of those children have 0 matches, and still they are doing well after a few years of transplant. So more important thing is to look at the blood group, but with the recent immunosuppression techniques, I think we are trying to have a successful renal transplant down the line. We have initiated a virtual cross match that in 2020. Now, previously we used to do a flow cytometry, which was a bead assay for a flow cross match, but that took time. That required recipient recipient cells to be present, and it was very expensive. But nowadays, since 2020, we initiated this. It's a solid phase assay, and it does not require viable donor cells. So it does. If you have an HLA typing of the donor, which is usually entered in the database, you can get quick results. It's less expensive. It decreases the ischemia time, and we can improve. we can decide whether we want to accept this offer, we want to decline this offer. That's a huge advantage for any transplant program. More and more transplant programs are switching to virtual cross-match. We started switching to the virtual cross-match in 2020, and I think so far we have done well with decreasing our cold ischemia times and accepting the offers. Also, we are implementing we are implementing the donor cell-free DNA assessment. We have started this laboratory study. This is what actually this is it studies the disease donors cell-free DNA in the blood. So if their cell-free DNA is high in the blood compared to is higher in the blood, then that can be a marker of active rejection. So if sometimes the creatinine may not rise higher enough, and we know if there is a borderline rejection or if they are just starting to get rejection, then this study can help. This is a marker which can help to make a determination to whether we want to do a biopsy or whether you want to start a treatment for rejection. So we have started this study as well, and I think some of the pediatric transplant programs are implementing this assessment. I'm going to stop here to ask any questions. My references are attached to the slides, and I'm open to any questions.
Sid, once again, you have given a fantastic lecture with great explanation of things. I'm intrigued about that progression at puberty. If it's based on males versus females, is it a matter of muscle mass, and is there any benefit in trying to minimize teenage boys developing more muscle mass using things like spironolactone as an androgen inhibitor to increasing muscle mass, or are there things that could be done to minimize that progression?
Yeah, that's a great question, and I honestly am very ambivalent about answering it rightly. But I would tell you that to my experience and the years I've been here, I think that I usually restrict creatinine or any of the supplements in adolescent boys who have chronic kidney disease. I tell them not to use creatinine supplements. Now, there may be some nephrologists who may not agree with me, but I do tell them to restrict the creatinine or those protein supplements. Now, the recent KDIGO guidelines say that if your child is in CKD stage 1, 2, or 3, you do not need to restrict protein intake. But once they are at stage 4 and stage 5, and when there is a more risk of progression or requirement of dialysis, then you want to think, because then the question of azotemia comes. The muscle, I try to restrict the supplements in those children, in those adolescents, and also particularly, sometimes they are working in the gyms, they are athletes, they are wrestlers, and it's sometimes hard to convince them, but I do try to restrict them. Now, I do not have studies to show, I do not know of studies to show that would actually help in those boys restricting the supplements, but no large scale studies done in adolescent boys on that aspect. But I would theoretically, I think it makes sense to restrict those supplements and creatinine, spironolactone, things like that in those adolescents.
Is there any relationship to adiposity?
Yes, adiposity is related to chronic kidney diseases. Particularly, we have seen new roles of hormones like leptin, adenopectin, those hormones from the adipose tissue, and how some of those hormonal factors can lead to progression of CKD. Adiposity, not just by hypertension. I mean, you're talking about hypertension with obesity or adiposity, but also the hyperlipidemia, and more programs are recommending starting lipid lowering therapies, dietary changes, stricter blood pressure control. Also, there are conditions like obesity associated FSGSs or secondary FSGSs from obesity, but obesity is a huge factor, I think, and I've seen obesity can significantly lead to progression of CKDs, even in children who do not have glomerular diseases, who have like K-cut groups, who have like just renal hypodysplasia or obstructive uropathies. In those patients, even it can affect the progression.
Thank you so much. I mean, it's a great talk and really have improved my understanding of things.
Thank you so much.
Thank you so much, Dr. Shaw. There's another question in the chat from Dr. Roberts. It says, can you comment on the risk of chronic kidney disease with ectopic kidneys and horseshoe kidneys? And how should these newborns and children with these conditions be followed?
That's a very good question also. So ectopic kidneys are when the kidneys are in the pelvic position, they do not ascend normally to their normal position, which is higher up. And we have seen that when you have an ectopic kidney, there is down, ectopic kidney by itself is in literature we are not saying that it's an abnormal kidney. You can have a totally normal ectopic kidney functioning totally normally, and that's totally possible. But with ectopic kidney, there are some risks that needs to be followed. I would recommend doing periodic ultrasounds to monitor the growth of the kidneys. And also we see patients in the clinic with ectopic kidney, so those patients can be referred to our clinics. Also, there is a very small chance if there was like abnormality on the normal kidney, like let's say there is hydronephrosis, then there is a small chance of like reflux, or there is a very small chance of UPG obstruction. Those chances are very small. That are like in the literature, it's like 5 to 10%. But that's why we would like to follow those patients, so we could see that if there was any hydronephrosis or if there was something, then we can evaluate those conditions. But ectopic kidney by itself, you can still have having normal ectopic kidney, and children who have ectopic kidneys usually have very good prognosis down the line too. I think the question also asks about the sports restriction. With that, usually the current task force, again, the nephrologist practice can be different, but when you have ectopic kidneys, I do not restrict sports. I usually tell them to wear kidney guards, and they are very helpful even with contact sports. And the studies have shown that if the children want to play football or they want to play contact sports, if they are interested, they are really motivated to do that, you should not restrict it if they are compliant wearing kidney guards, and they're very effective protecting the kidney. So I would say that those patients can be followed with us. Horseshoe kidneys, on the other hand, can be really normal variants. Some of these patients may not even require ultrasound periodically, like after a few years. It again depends on there are very few complications that can happen with horseshoe kidneys. And it can be, again, like you can have hydronephrosis or a slight increased risk of kidney infection or kidney stone, but that can be followed even at the PCP level. Many of the horseshoe kidney patients do not require referral to nephrology if the kidneys are growing well. I do recommend doing, if they want to be sure, you can do ultrasound in few years down the line if their kidneys are growing well. But horseshoe kidneys can be really have very good prognosis. Usually, if they are normal appearing, they are growing well, there is no hydronephrosis. Any other questions?
Dr. Shaw, there are no more questions in the chat, and so we will go ahead and end our presentation. Again, thank you so much for an excellent Grand Rounds, and I hope everyone has a great rest of their days.
Thank you.